Welcome back to the new section on Pheo-paragangliomas. In this particular section, as the name of the topic suggests, we are going to discuss on pheochromocytomas and paragangliomas and understanding the terminologies. First of all, is of paramount importance because these tumors behave a little differently with regards to the catecholamine secretion and the metastatic potential. We'll be discussing on the basics of these tumors, and at the same time, we'll also be discussing on advanced concepts, especially the workup and the management, which has grown leaps and bounds in the last 1 to 2 decades. And this is a very, very important topic, so please pay proper attention. So let us start with the basics as usual, like what we are doing in the other topics as well. And we'll be starting this topic with neural crest cells. We have to go back to a little bit of embryology to understand the terminologies better. So these neural crest cells are the cells which are going to bud off from the neural ectoderm at the time of formation of this neural tube. These neural crest cells give rise to a variety of structures in the embryonic life. We know that right from the craniofacial bones to your melanocytes and especially your autonomic nervous system ganglion as well. So with this particular chapter's regard, we have to know that these neural crest cells are the ones that are going to form this autonomic nervous system as well. So with regards to the autonomic nervous system, which is very important in this particular chapter, there are two cell types that these neural crest cells give rise to. The first type of cells we refer to as neuroblasts. These neuroblasts are the ones which are going to form the autonomic nervous system ganglia, including both the sympathetic nervous system as well as the parasympathetic nervous system. And the second type of cell that they're going to form are the non-neuronal cells. These non-neuronal cells are also referred to as paraganglion cells because neuroblasts form the ganglion cells and these non-neuronal cells form the paraganglion cells, and these paraganglion cells are going to be located just adjacent to the ganglion cells and the ganglia, and that is why these are called as paraganglion cells. And these neuroblasts, as I told you before, they are going to form the parasympathetic nervous system ganglia, and they're going to also form the sympathetic nervous system ganglia. So remember, the parasympathetic nervous system ganglia are the ones that are going to give rise to this postsynaptic parasympathetic neurons, and this sympathetic nervous system ganglia are the ones that are going to give rise to this postsynaptic sympathetic neurons. But understand that this sympathetic nervous system ganglia is what you're going to see in the adult life and the childhood as this paravertebral and prevertebral sympathetic ganglia. Remember, this paravertebral sympathetic ganglion chain is very famous. It starts right from the base of the skull up to the level of the coccyx. You have this paravertebral sympathetic chain, and prevertebral sympathetic chain are also very famous, with the famous example of celiac ganglion and multiple other ganglions that are located in the abdomen, right? So they are going to give rise to this postsynaptic sympathetic neurons. But there are some neuroblasts which migrate and come to a very, very special area, and we obviously know what this special area means. This is the adrenal medulla. Clear? So which means I can write there are some neuroblasts which migrate towards the adrenal medulla, and these are the neuroblasts that are migrated to the adrenal medulla, and they are going to form the sympathetic nervous system neurons within the adrenal medulla, which is going to actually control this adrenal medullary catecholamine secretion. Whereas these non-neuronal cells, that is the paraganglion cells, can be divided into two groups of cells. The first group of cells are the chromaffin cells, whose location will be in the sympathoadrenal location. They are also referred to as sympathoadrenal paraganglion cells, or otherwise referred to as a more basic terminology called chromaffin cells. The reason why they are called chromaffin cells is because chrome, that is color, they are having affinity towards this color because they contain these neurosecretory granules. That is the reason. And second group of cells we are going to call it as non-chromaffin cells. These non-chromaffin cells are going to be called as parasympathetic paraganglion. So we have two types of paraganglion cells. One is the sympathoadrenal paraganglion cells, and second one is the parasympathetic paraganglion cells. The sympathoadrenal paraganglion cells are specialized cells which we are going to call it as chromaffin cells because they are going to secrete and generate catecholamines, but whereas this parasympathetic paraganglion cells will not secrete catecholamines. These chromaffin cells are located in two areas. Obviously, they will migrate to the adrenal medulla. Some of these cells will be migrating to the adrenal medulla where they will be called as pheochromoblasts. These are nothing but the chromaffin cells that are migrated to the adrenal medulla. And these pheochromoblasts will form mature pheochromocytes. These are nothing but mature chromaffin cells which is going to secrete catecholamines with perspective to the adrenal medulla. They are going to secrete epinephrine or adrenaline as a major catecholamine. The reason why adrenal medulla is going to secrete a lot of epinephrine compared to the other areas is the fact that these chromaffin cells contain this PNMT enzyme, that is phenylethanolamine N-methyltransferase, which is cortisol dependent. We have discussed this already. So since this enzyme is cortisol dependent, such a high concentration of cortisol that is required for this enzyme to keep going is present only in the adrenal region. So that is the reason why adrenal medulla has this radial blood supply, and that is also the reason why adrenal medulla is the only source for this epinephrine secretion. Similarly, these chromaffin cells can also migrate to a variety of extra-adrenal locations. So, what are the sites of these extra-adrenal locations where they can migrate? Well, they can be located right from the base of the skull up to the level of bladder and prostate. Till this area, they can migrate. And remember, these chromaffin cell clusters that are located adjacent to the sympathetic ganglion, which can be present anywhere from the base of the skull to the bladder and the prostate, they are also having PNMT enzyme, but they won't be having this much amount of cortisol that is present in the adrenal gland to drive this PNMT enzyme to secrete this epinephrine. So, which means they are going to secrete noradrenaline, or I can write norepinephrine. I mean, both are same, isn't it? So, they're going to secrete noradrenaline as a major catecholamine. Clear? One of the largest collection, extra-adrenal collection of this chromaffin cells is the organ of Zucker-Candle. Organ of Zucker-Candle, which is actually located at the aortic bifurcation, right? So near the aortic bifurcation, this organ of Zucker-Candle will be located. In the embryonic life, this organ of Zucker-Candle forms a major source of catecholamines in the blood for the fetus. But later on, this extra-adrenal rests of this chromaffin cells generally tend to regress, where adrenal medulla is going to take over as the major source of catecholamine that is going to circulate in the adult life. So, what about this paraganglion cells which contribute to the parasympathetic, which are present adjacent to the parasympathetic nervous system? So, what will be the location of this non-chromaffin cells, that is parasympathetic paraganglion cells? Remember, the location of these cells are usually in the base of skull and the neck, where they will be usually located along the branches of glossopharyngeal nerve and the vagus nerve. So, cranial nerve 9 and 10. So, they will be usually located along the branches of the glossopharyngeal and the vagus nerve. So, the usual locations are in the carotid body. We know that the cells that are located in the carotid body are going to function as these chemoreceptors, and there are also other locations where this parasympathetic paraganglion can be present, like for example in the jugulotympanic region, in the vagal region, and in the prelaryngeal region. So these are some other locations where you can see this parasympathetic paraganglion cells. Now let us see the tumors that you can get from this embryological understanding. The tumor of this neuroblasts that have migrated to the adrenal medulla are called as neuroblastomas, as the name suggests, and the neuroblastomas are very important tumors in the infantile life, and the most common cause of abdominal mass in infantile life is likely to be a neuroblastoma. Very important from pediatric perspective, which will not be discussing in the particular chapter. And the tumor of this pheochromoblasts. So these pheochromoblasts are nothing but these chromaffin cells that have migrated to the adrenal medulla, and the tumor of this pheochromoblasts is what we refer to as pheochromocytomas. And the old terminology for this pheochromocytomas or adrenal pheochromocytomas, but remember, there is nothing like adrenal and extra-adrenal right now. All the adrenal medullary tumors that are chromaffin cell tumors will be called as pheochromocytomas. That's it. Which means this extra-adrenal chromaffin cell tumors, which means the chromaffin cell tumors that are located elsewhere apart from the adrenal region, will be called as paragangliomas. To be precise, you can call them as sympathetic paragangliomas. But the old terminology for this is extraadrenal pheochromocytoma, but do not use that term. Currently, they are simply called as paragangliomas. To be specific, you can call them as sympathetic paragangliomas. And the parasympathetic paraganglion cells, if they go for a tumor, they'll be called as parasympathetic paragangliomas. Clear? That is the reason why this sympathetic paragangliomas and parasympathetic paragangliomas, you can also call them as simply paragangliomas. That's why the whole spectrum of these tumors will give rise to this Pheo-paragangliomas. For that matters, you can argue that pheochromocytoma is also a type of paraganglioma because the origin of this pheochromocytoma is from this paraganglion cells only. That is why pheochromocytoma is also a type of paraganglioma from the hindsight, but that should not be called as paraganglioma. So final nutshell, I'll tell you, chromaffin cell tumors of the adrenal medulla, definitely pheochromocytoma, no other terminology, and chromaffin cell tumors elsewhere in the body apart from the adrenal medullary region, you will be calling it as sympathetic paraganglioma or simply paraganglioma. And this parasympathetic paraganglioma, parasympathetic paraganglion cells, they go for a tumor, will be called as either simply a paraganglioma. To be specific, you can call them as a parasympathetic paraganglioma as well. Clear? So what is the old terminology for this parasympathetic paragangliomas? They have been called by a variety of names like glomus tumors, which should be avoided. At the same time, they also have been called as chemodectomas. And again, this terminology should be avoided. Why they are called as chemodectomas? Because we know that this carotid body functions as this chemoreceptor. So since this is a tumor of this chemoreceptors, they have been called as chemodectomas. But again, you know very well, only the carotid body is going to act as chemoreceptor and the other regions are not going to act as chemoreceptors, and hence the term chemodectomas also should be strictly avoided. So let us compare and contrast these tumors and how they are going to perform. First of all, with the sites. Obviously, we know pheochromocytomas, only one site, that is the adrenal medulla. That's it, nothing else, nowhere else. Only in the abdomen, that is in the adrenal medulla. Only adrenal medullary tumors will be pheochromocytomas. Very clear. And this sympathetic paragangliomas can occur in many sites, but the most common location is in the abdomen. Very commonly in the area of organ of Zuckergandl, which can wake up later in life. Usually in the childhood, they go for regression. In embryonic life, they are very active. But in the childhood, they regress, adrenal medulla takes over. But later in life, in the early childhood or probably in the adult life, they might wake up and they can produce a tumor which can give rise to this paraganglioma, which is nothing but previously called as extraadrenal pheochromocytoma. Abdomen is the location for almost 75% of the sympathetic paragangliomas. But remember, these chromaffin cell clusters can be distributed right from the base of the skull up to the region of the bladder and the prostate. So you can see in other areas also apart from the abdomen, like in the skull base, where you can see the distribution of almost 5% of the sympathetic paragangliomas, and thorax as well, where you can see 10% of this sympathetic paragangliomas. And in bladder and prostate, once again you will be seeing almost 10% distribution in these areas. But obviously the most common location will be in the abdomen without a doubt. 75% of the cases will be located in the abdomen only, sympathetic paragangliomas. And for parasympathetic paragangliomas, usual location will be in the neck. As I told you, this parasympathetic paraganglion cells will be located in the base of the skull and the neck, but most common site will be the neck, where they will be originating from the carotid body. This carotid body paraganglioma is the commonest, previously called as carotid body glomus tumor or simply a carotid body tumor or a chemodectoma. Currently, we don't use these terminologies, simply stick on to the term carotid body paraganglioma. And other sites also possible, like for example, you can see in the skull base. For that matters, there are two tumors that can originate in the skull base. One is the jugulotympanic region. Previously, this jugulotympanic paraganglioma was called as this glomus jugulare, which presents with the pulsatile tinnitus with bone erosions. But currently, we don't use the term glomus jugulare. Instead, it's better to use the term jugulotympanic paraganglioma. or it could be even a vagal paraganglioma, right? So, and it can happen in other areas of the neck as well. For example, a prelaryngeal parasympathetic paraganglioma, which is actually quite rare, very, very rare. Fine. So, these are the sites of parasympathetic paraganglioma. And what about the functionality or the functional status of these tumors? Remember, almost 9 out of 10 pheochromocytomas are functional. 90% of the pheochromocytomas are functional, which means they actively secrete catecholamines, and the most important catecholamine is the epinephrine, or they can secrete this norepinephrine as well. Clear? But I mean, depending on the genetics and the size of the tumor, which determines whether they will secrete epinephrine or norepinephrine. But the most important and the most common is the epinephrine, and the most important is the epinephrine again. Clear? I mean, we'll be discussing why epinephrine is very important with respect to pheochromocytomas in some time. And functionality of these tumors, yes, they are functional in almost 50 to 70%, which means mostly they are functional, this sympathetic paragangliomas. And the most important neurotransmitter most important catecholamine they are going to secrete is the norepinephrine, very rarely dopamine. But they really do not secrete epinephrine because I told you only adrenal medulla has this unique property of this converting this norepinephrine to epinephrine, because chromaffin cells in general have this PNMT enzyme. But adrenal medulla is the place where you have this high cortisol levels that will drive this PNMT enzyme to produce epinephrine. These other chromaffin cells clusters apart from the adrenal medullary region will not be having this sufficient cortisol drive to produce this epinephrine. That is the reason why they are going to produce only norepinephrine and not epinephrine, which means whatever epinephrine you see in the blood, it comes from the adrenal medulla only, nowhere else, which I have discussed already in the basic section. And this parasympathetic paragangliomas, they tend to be non-functional. Less than 1 to 2% of the parasympathetic paragangliomas tend to be functional. If they are functional, they will secrete dopamine mostly, rarely noradrenaline, but definitely not adrenaline. And what about the malignancy rate? Traditionally, malignancy rate was approximately 10%. That was the rule of tens, which told that 10% of the tumors are non-functional, 90% are functional, 10% are non-functional. And the second rule of 10 is 10% are malignant. But with the advanced detection rates and long-term follow-up, we are now picking up more malignancies than the rule of tens is going to tell. That is 15 to 20% malignancy rates are there for pheochromocytomas in the current era. But the malignancy rates of this sympathetic paragangliomas are exorbitant, around 40 to 50% of sympathetic paragangliomas. Once upon a time, they have been called as extradental pheochromocytomas are malignant. Usually, these parasympathetic paragangliomas tend to be non-malignant. You can see these parasympathetic paragangliomas are non-functional as well as non-malignant. Then how they present? Usually they present with local mass effects because of the tumor growth. Apart from that, they will be non-functioning, which means they won't present with hormonal excess state, or they won't be presenting with malignancy features also. Usually they will be presenting with mass effect or pressure effect to the adjacent structures because of the growth of the tumor. That's all. So these are the some differences between pheochromocytomas and paragangliomas, and you have to understand the terminologies better because they behave differently in the catecholamine secretion perspective, at the same time malignancy perspective, which has a huge impact in the prognostic evaluation as well as the workup and the treatment of this tumor. So be very careful in the terminologies. After understanding this, we'll be moving on to the biochemistry. Biochemistry of this catecholamine synthesis is very important, and the degradation is very important to understand why we use certain markers for certain tumors. So first, you know, the catecholamine synthesis starts with the basic raw material, that is tyrosine, which will be converted to L-DOPA by a rate-limiting enzyme called tyrosine hydroxylase. This L-DOPA will be further converted to dopamine, which is the first basic neurotransmitter and catecholamine, by an enzyme called aromatase L-amino acid decarboxylase, or simply we can write as DOPA decarboxylase. This dopamine will be further subjected to a reaction by an enzyme called dopamine beta hydroxylase, or simply we can call it as dopamine hydroxylase, which will produce this norepinephrine, which will be further converted to epinephrine, by our iconic PNMT enzyme that is called phenylethanolamine N-methyltransferase. Remember, this phenylethanolamine N-methyltransferase enzyme is present only in chromaffin cells, but that too in chromaffin cells only adrenal medulla will produce this epinephrine because this PNMT enzyme needs cortisol. That much cortisol can be given only in the environment that is likely to be in the adrenal gland. Apart from that, extra adrenal chromaffin cells cannot produce epinephrine because they do not have that much amount of cortisol to drive the PNMT enzyme, which you have discussed already. So this dopamine, norepinephrine and epinephrine is what we famously call as catecholamines. And what is the degradation of this dopamine, norepinephrine and epinephrine? All are subjected to a very, very important enzyme called as COMT, that is catechol-O-methyltransferase, which will convert dopamine to a compound called methoxytyramine. So, and that is the reason why this methoxytyramine is considered as a marker for dopamine secreting tumors. So, it's a marker of dopamine. So, I can write as a dopamine marker is methoxytyramine. Similarly, this noradrenaline will be converted, norepinephrine will be converted by COMT to normetanephrine. And that is the reason why this normetanephrine is considered as a noradrenaline marker or a norepinephrine marker. So, norepinephrine secreting tumors will be predominantly having normetanephrine. And this epinephrine will be converted to metanephrine by the same PNMT enzyme, and that is the reason why this epinephrine marker is the metanephrine. So, this metanephrine is considered as an epinephrine marker. And we know that all the epinephrine that you see in the circulation, almost 100%, every single molecule of epinephrine that you see in the circulation should come from adrenal medulla. Fine. And the tumor of the adrenal medulla is what we refer to as pheochromocytoma, right? Which means whatever epinephrine in the setting of a tumor that is seen in the circulation should come from this pheochromocytoma, which is a tumor of the adrenal medulla. Remember, pheochromocytoma can produce epinephrine as well as norepinephrine, which will be predominantly produced, will be determined by the genetics and the size of the tumor, both. But whatever epinephrine you see in the circulation should come from adrenal medulla only. In the setting of a tumor, it means it's a pheochromocytoma, which means whatever metanephrine you see in the blood must be coming from epinephrine only, must be coming from adrenal medulla, or in the tumor setting, whenever metanephrine's are elevated, that is equal to pheochromocytoma. That's it. Without a doubt, elevated metanephrine's means equal to a pheochromocytoma. Fine. But this elevated normetanephrines can be either coming from a pheochromocytoma or any other paraganglioma for that matters, which means the norepinephrine source, if you split, almost 90% of the norepinephrine that you see in the circulation is coming from the sympathetic nervous system, and approximately 10% of the norepinephrine that you see in the circulation is coming from the adrenal medulla. We know that fact already. So, which means this normetanephrine in the circulation can come from other sources of sympathetic nervous system as well as from the adrenal medulla, which means this elevated normetanephrines can symbolically tell it could be either a pheochromocytoma which is producing norepinephrine and producing excess normetanephrine, or it could be a paraganglioma. So, in the case of Pheo-paraganglioma, you might have a normetanephrine excess. You might argue the fact, sir, why we should not directly see the norepinephrine and epinephrine, why we want to see this normetanephrine. Remember, this epinephrine and norepinephrine are not stable stable compounds, and their levels are subjected to serious physiological changes, which means even a simple anxiety can increase epinephrine and norepinephrine levels, and they can fall down immediately after that. So, their levels are not stable, but their metabolites, that is normetanephrine and metanephrine, are relatively much more stable, and that's why they are used as standard markers for this pheochromocytomas and paragangliomas. For that matters, if the patient is having elevated metanephrine, irrespective of whether normetanephrine is elevated or not, if there is 2 to 4 fold elevation of metanephrine is equal to pheochromocytoma, no doubt about that. If the metanephrine's are normal but only the normetanephrines are elevated, in that setting I will be diagnosing a paraganglioma rather than a pheochromocytoma. Clear? Very simple. Similarly, when the normetanephrines and metanephrines are normal, only the methoxytyramine is elevated. In that setting, I will be diagnosing an asymptomatic parasympathetic paraganglioma because usually that's the setting, because these parasympathetic paragangliomas are the ones that are non-functional generally, and they can release excessive dopamine which doesn't have function usually in the body. And that is the reason why in the setting of normal metanephrine and normetanephrine with an elevated methoxytyramine, I'll be diagnosing an asymptomatic, probably a parasympathetic paraganglioma. Clear? So this methoxytyramine, metanephrine and normetanephrine can be further subjected to degradation by monoamine oxidase, which is going to produce a common compound called MHPG, which will be further degraded to our famous vandyl-mandelic acid, which will be excreted in the urine finally. And vandyl-mandelic acid is not a good marker because of its high rates of false positives and false negatives. At the same time, it cannot tell you whether it's a pheochromocytoma or a paraganglioma, and in any patient with the Pheo-paraganglioma, vandyl-mandelic acid can be elevated. Clear? So it cannot tell you whether it's a pheochromocytoma or a paraganglioma. Using normetanephrine and metanephrine, I can tell whether it's a pheochromocytoma or a paraganglioma. But in the elevation of vandyl-mandelic acid will not tell you whether it's a pheochromocytoma or a paraganglioma. That's why it's a very, very outdated biochemical test. We don't use vandyl-mandelic acid anymore. Apart from studying in biochemistry, you just remove that and don't use it in the current practice. Now let us move on and see in a little bit more detail. For this, I need a diagram, because this diagram is important to understand the false positives, why it happens with normetanephrines and metanephrines. So let me draw a diagram. For that, let us see, this is a blood compartment, and you have a sympathetic nervous system neuron. This is a sympathetic nervous system neuron, which is going to release noradrenaline in the local synapse. And this noradrenaline will be acting in the postsynaptic terminal, and once the action is complete, majority of this noradrenaline will be taken back into the neuron itself by a lot of transporters called as reuptake transporters, and some of this noradrenaline will be reaching the blood compartment. And remember, the 90% of noradrenaline that you see in the blood is coming from the sympathetic nervous system only. That's a very, very important point. But remember, there are some amount of noradrenaline that is seen in the blood is coming from the adrenal medulla as well, little amount. So I can write adrenal medulla here. So where adrenal medulla also secretes norepinephrine. If 10 to 15% of norepinephrine that you see in the blood is coming from the adrenal medulla only. Remember, this noradrenaline can be taken by a variety of non-neuronal cells. So for example, let me tell, this is an example of a non-neuronal cell which will take some of this norepinephrine, and they process with the enzyme called catechol-O-methyltransferase, where they're going to produce this normetanephrine, which will be released into the circulation. So remember, whatever normetanephrine that you see in the circulation, almost 75% of the normetanephrine is coming from the sympathetic nervous system only. 75% of the normetanephrine and 90% of the noradrenaline that you see in the circulation is coming from sympathetic nervous system. That's why normetanephrine is an important marker with regards to paraganglioma, but elevations can be seen in pheochromocytomas also, because this norepinephrine can be converted to normetanephrine by the adrenal medulla itself, which means 25% of the normetanephrine that is seen in the circulation is contributed by the adrenal medulla. So normetanephrine elevations can be seen in either a paraganglioma or a pheochromocytoma, which is an adrenal medullary tumor. But what is the important point here to understand is the fact that this epinephrine, whatever epinephrine that you see in the circulation, 100% is coming from the adrenal medulla only, because only adrenal medulla can activate this PNMT enzyme because of the high cortisol levels in the adrenal gland. So almost every single epinephrine molecule, as I told previously, in the circulation is coming from the adrenal medulla only. And we know that epinephrine is the one that is going to produce this metanephrines, and these metanephrines can be coming either from adrenal medulla, where 90% of the metanephrines are going to come from adrenal medulla through the activity of COMT, where some of the epinephrine that is released in circulation can be taken by this non-neuronal cells, where they have this COMT activity, and 10% of the metanephrine in the circulation can be due to metabolism by non-neuronal cell also. Don't get confused by the fact that non-neuronal cell also gives rise to metanephrine. But you have to understand the basic fact that whatever metanephrine you see, it is going to come from epinephrine, and every single molecule of epinephrine that you see in the circulation is coming from adrenal medulla only, which means directly or indirectly, every single molecule of metanephrine is also contributed by the adrenal medulla only. So that's why elevations of metanephrine is equal to pheochromocytoma. Elevations of normetanephrine can happen either in a pheochromocytoma or a other paraganglioma also. So why you wanted to understand this complicated diagram? I told you all these things in a very simplified diagram in the previous minutes itself. Why you want such a complicated diagram? To understand the false positives, that's why. So all these metabolites will be excreted in the urine. That's the reason for the first false positive I'm going to explain, that is renal failure. Whenever there is renal failure, there will be accumulation of metabolites in the body, and that is the reason why it can result in false positive or falsely elevated levels of metanephrine and normetanephrine. So we are talking about false positives. So similarly, whenever there is extreme sympathetic surge, which means in critical illness, you will have excessive sympathetic nervous system activity, which can even result in excessive norepinephrine as well as epinephrine production, which in turn can increase the metanephrine and normetanephrine levels. So that can result in false positive values. So like for example, excessive sympathetic drive, which can happen in critical illness, extreme stress. Nobody is going to take metanephrine and normetanephrine if the patient is intubated, right? Or this can happen due to very common procedural fault, like if you take blood in non-supine posture. Remember, taking blood for metanephrine and normetanephrine means the patient should be at least lying down for 30 minutes in supine posture. Then only you should take blood. If the patient is in non-supine posture, very likely you will end up in a false posture, because in a non-supine posture, when you are standing erect, there will be too much catecholamine activity, because to prevent the postural fall in BP when you are standing, to prevent the peripheral fluiding, there will be continuous release of catecholamines which produce this venous constriction in the lower limbs to push the blood back into the peripheral circulation, which can produce a false positive values of catecholamines as well as metanephrine and normetanephrine. So don't do that. And third, certain medications and drugs can itself result in false positive elevations of metanephrine and normetanephrine. So what are the medications? First medication is the adrenergic blockers. So either an alpha or a beta adrenergic receptor blocker will result in incomplete capture of this adrenaline and noradrenaline, resulting in more spillage into the blood, resulting in more catecholamines in the blood as well as more metanephrine and normetanephrine. At the same time, because of the receptor level blockade, there will be more synthesis of epinephrine and norepinephrine, and that is also one of the reasons why you will have falsely positive elevations of metanephrine and normetanephrine. Now, first one is the alpha and beta adrenergic receptor blockers. Second one is the reuptake inhibitors. Lot of reuptake inhibitors, for example, SSRIs, which can predominantly inhibit the reuptake of serotonin, but can inhibit the reuptake of other biogenic amines also. Tricyclic antidepressants, which can result in inhibition of reuptake of multiple biogenic amines. For example, cocaine. Cocaine is also powerful noradrenaline reuptake inhibitors. So all these things can result in false positive elevations of metanephrine and normetanephrine, because this blockade in the reuptake once again will result in spillage of this epinephrine and norepinephrine into the circulation, resulting in more and more production of metanephrine and normetanephrine. And we have infusions of epinephrine or norepinephrine or dopamine in the ICU, which is a no-brainer, that can produce more catecholamine in the circulation, more metanephrine and normetanephrine in the circulation. Or if the patient is using L-dopa, like in Parkinson, the L-dopa can be processed to dopamine and further to norepinephrine, metanephrine, which can be further degraded to metanephrine and normetanephrine, and that's why this is also one of the reasons for falsely elevated values. And finally, MAV inhibitors can also produce, because we know this MAV is the one that converts this normetanephrine, metanephrine to VMA, so there can be falsely elevated values of normetanephrine, metanephrine with MAV inhibitors as well. So these are some of the medications that can result in false positives. But please do understand the fact, the false positives usually lie in the range of mild elevations only. They will not cause significant elevations. Only mild elevations in this metanephrine and normetanephrine, usually in the range of 1 to 2 times the upper limit of normal, should be considered to have a probable false positives. But any elevations more than 2 to 4 times the upper limit of normal, this is definitely true positive. And in this setting, you should always diagnose a functioning Pheo-paraganglioma. But remember, whenever the patient is having only mild elevation, it could be a false positive or it could be a early Pheo-paraganglioma, which means it could be a early true positive also. In early stages, it could have a mild elevation, but massive elevations like more than 2 to 4 times the upper limit of normal is almost always equivalent to a functioning Pheo-paraganglioma only. They are completely true positives for sure. Clear? At the same time, I would also like to tell, I think I mentioned this previously, this metanephrin and non-metanephrin cannot be falsely negative, which means false negatives are impossible, which means they have 100% negative predictive value, which means whenever the metanephrin and non-metanephrin are normal, it rules out a functioning Pheo-paraganglioma. It can be non-functional, but still functioning Pheo-paraganglioma is ruled out in the presence of normal metanephrins and non-metanephrins, which means you can have a true positive, you can have a true negative also, but you cannot have a false negative. You can have a false positive also, but you can never have a false negative because they have 100% negative predictive value. Clear? After knowing this, let us move on to the ever important genetics of this Pheo-paragangliomas. Remember, 10% of the pheochromocytomas are familial. You know the rule of tens. But when you take a Pheo-paraganglioma as a whole, the familial percentages will go exorbitant because majority of the paragangliomas are actually familial. So that you cannot exactly tell how much percentage are familial, but with the advent of more and more discovery of more genes, the amount of genetic association with Pheo-paragangliomas are increasing. That's why this is a very, very important point. So genetic wise, you can split the Pheo-paragangliomas into two. One is the sporadic variety, still this remains the most common form. And second one is the familial form, but a very sizable number. So you have to know this. Familial forms can be further divided into syndromic forms and probably non-syndromic varieties, whether they are associated with a certain syndrome or not. Non-syndromic forms are usually associated with mutations in the SDH component. Why I written SDH-X is the fact that X means there are multiple subunits of the succinate dehydrogenase complex, which is increasingly recognized as a cause of this many familial Pheo-paragangliomas. And syndromic associations, very common in exam, they will ask you the association with red proton oncogene, which means they are associated with this MEN2 syndromes, or you can be asked with the association of neurofibromatosis type 1, von Reckling-Olsen disease, where NF1 gene, chromosome number 17, red gene is in chromosome number 10. And number 3, it can have association with von Hippel-Lindau syndrome also, which is a tumor suppressor gene present on chromosome number 3. Clear? So now a new syndrome has been coming up, that is carnase trichiase dyad. This is coming up in a very nice way, carnase trichiase dyad. So what do you mean by carnase trichiase dyad? It is different from the carnase triad. Carnase triad is a combination of 3 tumors: paraganglioma, pulmonary chondroma, and GIST. Carnase trichiase dyad is a combination of only 2 tumors. You exclude pulmonary chondroma from triad, you will result in dyad. So what are the 2 tumors remaining? GIST and paraganglioma will come under carnase trichiase dyad. Then why can't you add a carnase triad? The reason why we don't add this carnase triad here is because the carnase triad does not have any genetic basis, but dyad has the genetic basis in the form of KIT mutations, PDGF receptor alpha mutations, and at the same time you can have multiple SDH gene mutations like B, C, D component of succinate dehydrogenase complex as well. So these are some of the syndromic relationships with Pheo-paraganglioma. Remember, carnase triad has no genetic basis, no genes have been identified for carnase triad. That's why I'm not writing in the familial Pheo-paraganglioma. So remember that carnase triad can be put under sporadic forms only. Cannot be coming under familial forms. So one interesting association is the fact that this red proton oncogene and NF1 related pheochromocytomas or Pheo-paragangliomas will be more of adrenaline producing or epinephrine producing. They won't produce noradrenaline. Usually they will have a very high PNMT activity, and they are non-hypoxic pathways also. Clear? But there are 2 hypoxia related pathways which we'll be discussing subsequently. VHL and SDH is related to hypoxia pathways, and this hypoxia pathway related Pheo-paragangliomas tend to produce more of noradrenaline than adrenaline because they tend to have a reduced PNMT activity. Very, very important point. Similarly, this sporadic forms, whether they produce adrenaline or noradrenaline, will largely dependent on the size of the tumor. So usually small size tumors generally tend to produce adrenaline. Large size tumors generally tend to produce noradrenaline, even though that's not important and there is no cutoff for small versus large tumors. But in general, large tumors tend to produce more of noradrenaline and small tumors tend to produce more of adrenaline. Why is that so? We know that adrenal gland is going to have a radial blood supply, and we know the importance of this radial blood supply as well. And any tumor that is originating in the adrenal medulla, and if it is small, remember pheochromocytomas are absolutely vascular and they are highly vascular, which means they are very much dependent on the blood supply. And this small tumors needs, so if we take this as a small tumor, and this small tumors needs can be entirely satisfied by the native adrenal blood supply itself. Native adrenal blood supply is is radial and it's containing a lot of cortisol. So you know that PNMT enzyme that is going to be present in the tumor is also cortisol driven and cortisol dependent, and since it's a small tumor entirely dependent on native blood supply and they will have a lot of cortisol, they tend to predominantly produce adrenaline because of good activity of PNMT. But on the other hand, if you have a large tumor, if you have a huge tumor like this involving more than the size of the adrenal medulla itself, if you have a huge tumor, obviously the native blood supply will be supplying only the part of the tumor and the remaining tumor areas will be supplied by this new blood vessels. These are called as angiogenic blood vessels or neovascularization, and these are the ones that are going to supply majority of the area of the tumor, right? So which means this blood vessels that are not a part of the adrenal gland will not contain cortisol. They will be cortisol deficient or they will be cortisol naive and they don't have cortisol at all. So if they do not have cortisol, these areas PNMT enzyme will be there, but PNMT enzyme will not be active, which means this tumor is going to produce more of noradrenaline than adrenaline. So that is the reason why small tumors primarily tend to produce adrenaline and large tumors primarily tend to produce noradrenaline, even though in modern textbooks you won't find anything like that. So let us see the syndromes one by one in detail and what will be the characteristics of the pheochromocytomas. First is the MEN syndrome, especially MEN2A and MEN2B, which is related to this red proto-oncogene which is present on chromosome number 10. If it goes for mutation, that will result in this MEN2 syndromes. We know RET is a protein and it's a tyrosine kinase which is coming from the red gene. So this red protein has multiple domains. For example, it has a extracellular cadherin domain and another extracellular cysteine rich domain, and you have a transmembranous domain, and it has two tyrosine kinase domains, so TK1 and a TK2 domain. So usually the mutations will be either seen in the cysteine domain or TK1 domain or TK2 domain. So this will result in different MEN syndromes. For example, cysteine domain mutations will result in MEN2A syndromes, and this tyrosine kinase 1 domain mutations will result in familial medullary thyroid cancer, is called FMTC, and this TK2 mutations will result in severe forms of MEN syndrome called MEN2B syndromes, where you will see early MTC and even an early pheochromocytoma. But remember, in MEN2 syndromes, pheochromocytomas always happen after your medullary thyroid cancer only. So again, the codon mutations will determine which area of the protein will be having defect. For example, codon 618 mutation and 634 mutation will be usually causing the cysteine domain defect, resulting in MEN2A syndrome. That is why I told you in MEN2A the most common mutation is 618 mutation, but relatively more dangerous mutation is 634 because it results in relatively more serious disease. We have seen already in the MEN2 syndrome. And this TK1 domain mutations, very important one is the 883, which will result in FMTC. Most common mutation in FMTC is 883, codon 883 mutation. And TK2 domain mutation, important one is the 918 mutation. Remember, this 918 mutation is the most deadly and most serious, result in MEN2B syndrome. It's a TK2 domain mutation, so which causes this MEN2B syndrome. That is medullary thyroid cancer, pheochromocytoma, but they do not have a parathyroid adenoma. We have discussed this already. Most common mutation in MEN2B is this codon 918 mutations only. There are some characteristic features of this MEN2 related pheochromocytomas. For example, this MEN2A related pheochromocytomas, almost 30 to 50% tend to be bilateral, and they tend to happen in the 4th and 5th decade. But remember, any MEN2 related pheochromocytoma will happen almost always after medullary thyroid cancer only. It will not happen before MTC, which I have discussed already in the MEN syndrome chapter itself. And 66% of the patients may be asymptomatic. And even though they are bilateral, they tend to be benign compared to sporadic population and compared to MEN2B. They have lesser rates of malignancy. So these are some of the important features of this MEN2A related pheochromocytoma. In contrast, this MEN2B related pheochromocytomas tend to happen a little bit early, maybe in the 1st or 2nd decade, but almost always after MTC. There is no doubt about that. Similarly, 30 to 50% can be bilateral, and comparatively they have little bit more risk of malignancy in comparison with both MEN2A as well as general population. So more risk of malignancy. Overall, this MEN2 syndromes tend to produce increased risk of bilateral tumors. That is the reason why for treatment you prefer a bilateral adrenalectomy for that matters. And at the same time, they're more adrenaline producing. That is why the most important marker for MEN2 related pheochromocytomas will be metanephrin and not normetanephrine. Clear? Don't worry about this FMTC. FMTC usually will not result in pheochromocytomas. It's a pure MTC related syndrome. So I'm not going to write about FMTC. So these are some of the important points that you have to note with regards to the pheochromocytoma associated with MEN2 syndromes. Then next one is the neurofibromatosis 1, that is von Reckling-Olsen disease. The problem you know very well here. The problem is the NF1 gene, which is present in chromosome number 17, which is regarded as a tumor suppressor gene. So this NF1 gene produces a product called a neurofibromin. This neurofibromin is going to convert this RAS-GTP complex, which is active one, to RAS-GTP complex. We know this RAS-GTP, which is an active form, is a highly tumorigenic substance, which means it is a compound that is involved in cellular proliferation. They are going to activate the MAP kinase pathway and subsequent downstream pathways, which I have discussed in the basic section itself, which is going to further activate the mTOR pathway and cause cellular proliferation. So neurofibromin essentially is acting like a tumor suppressor protein. That is the reason why NF1 gene is like a tumor suppressor gene. So whenever you have problems in the NF1 gene, there will be significant downregulation of the neurofibromin protein, which means there will be significant downregulation of production of RAS-GTP. There will be increased RAS-GTP activity, which will further increase the MAP kinase pathways and mTOR activity, and that is the reason why you get tumors in this neurofibromatosis type 1. This is the basis of tumorigenesis with NF1. So what are the features? I'm going to discuss in detail in the neurology section, but still basic features we have to know. For example, they may have this cafeolate spots, they may have this freckles, especially in the axillary region. Axillary freckling may be there. They might have precocious puberty. They might have this Lish nodules, and they might have this growth hormone excess as well. And many other tumors also are possible. These are some of the basic features of neurofibromatosis type 1. But with regards to pheochromocytoma, pheochromocytoma happens in approximately 3% cases of NF1, and most of the pheochromocytomas associated with neurofibromatosis type 1 are unilateral, and there is 12% malignancy rates, which is not so high or not so low, which is almost equivalent to the general population. 12% malignancy rate is there, and usually they tend to happen at an older age compared to that of other syndromes and general population. And at the same time, there will be more of adrenaline producing than noradrenaline producing. That is the reason why important marker of NF1 related pheochromocytoma is metanephrin and not normetanephrine or methoxytaren. So these are some of the important points that you have to know. Then we can go to the tumorigenesis with regards to pheochromocytoma and Pheo-paraganglioma with respect to the hypoxia pathways. There are some hypoxia pathways that can result in this familial Pheo-paragangliomas. One is syndromic and another is non-syndromic. Syndromic is VHL and non-syndromic is this SDH related mutations. Both are related to hypoxia pathways only. First, let us see the syndromic VHL that is going to result in pheochromocytoma. The hypoxia pathway we already discussed in the hematology section itself. Let me recap it once again. So whenever you have a hypoxia, this hypoxia is going to increase the production of this hypoxia inducible factor HF1, especially 1 alpha and 1 beta. This in turn is going to bind to a nuclear factor called HF1b, and this complex is going to translocate to the genes, which is going to increase this erythropoietin production and VEGF, vascular endothelial growth factor production, which is going to produce angiogenesis. So remember, this inactivation of this HF1 can be done by a VHL gene, VHL protein. So for that, you need to hydroxylate this HF1 first, which is done by this PHD2 prolyl hydroxylase enzyme, which is going to produce hydroxylated HF1, which will be further subjected to degradation by this VHL protein coming from the VHL gene. Which means VHL gene is going to function like a tumor suppressor gene, because when you don't have VHL, you'll have excess activity of this HF1 and you'll have excessive binding to HF1b, which is going to produce more VEGF, resulting in more angiogenesis and tumor growth. So that is how your von Hippel-Lindau syndrome is going to produce a tumor. And similarly, PHD2 defects can result in familial erythrocytosis, which produce more of EPO, whereas this VHL defects will result in more of XVEGF, resulting in more of tumorigenesis rather than polycythemia. Clear? Remember, this hypoxia can also inhibit this PHD2, which again explains, because hypoxia you should have more HF1. So what are the tumors that are associated with VHL? The most important with regards to this particular chapter is the pheochromocytoma, which is fairly very important with regards to this particular chapter, wherein VHL 10 to 20% of the patients with VHL may have this pheochromocytoma, which means incidence is 10 to 20%, and most of them are bilateral, and there is a 7% malignancy risk is there. And majority of the tumors related to VHL will produce noradrenaline. That is why the marker that is preferred in VHL related pheochromocytoma is normetanephrine rather than a metanephrine, because they produce more of norepinephrine. There can be a lot of other tumors that are associated, like hemangioblastomas, very typically in the cerebellum, resulting in ataxia. They are cerebellar hemangioblastomas. They can produce vision problems due to this retinal angiomas. They can also produce this renal cell cancer and renal cysts. They can also produce endolymphatic sac tumors of the ear. They can also produce pancreatic cysts and neuroendocrine neoplasms of the pancreas. They can also produce this epididymal cystadenomas. Clear? Fine. So these are some of the tumors that are associated with von Hippel-Lindau syndrome, but most important is the pheochromocytoma. But very importantly, they happen at a very early age. Usually they can happen within 5 years of age. One of the very important DDs for early pheochromocytoma in life is VHL. Meant to be can produce, but they are exceedingly rare. So VHL is relatively common compared to that of meant to be, which is extremely rare. And second, non-syndromic association with this SDH components and this SDH succinate dehydrogenase complex related protein mutations can result in this hypoxia pathway activation, more and more HF production. And how they produce, a lot of hypotheses are there, but still SDH mutations are associated with hypoxia pathway activation. More HF, same, they are going to produce more of pheochromocytomas and paragangliomas. So what are the SDH complexes that is important to understand? SDH has many complexes. You have SDHA, SDHB, SDHC, SDHD, and SDH5, which is also referred to as SDH associated factor 2. This SDHA and B is important for catalysis. At the same time, SDHA is the one that takes care of this substrate binding, because this SDH is going to convert this succinate to fumarate. Clear? So this excessive succinate accumulation is the one that is thought to activate this HF1 and VEGF pathway. Clear? Because if SDH is mutated, there will be reduced fumarate and more succinate accumulation in the cell, which is the one that is thought to activate the HF1 in the cytoplasm. So this SDHA is the one that's going to bind with the substrate, and SDHB is going to do the electron transfer that is necessary for this step, and both can take part in catalytic reaction. And SDHC and D will be responsible for anchoring as well as binding to ubiquinone. Ubiquinone binding as well as anchoring is done by this SDHC and D, whereas this SDH associated factor 2 or SDH5 is associated with flavination of SDHA, because this flavination of SDHA is important for this substrate binding property of SDHA. So the flavination of SDHA is due to this SDH5 activity only. So depending on which subunit is affected, you will have different picture with respect to the Pheo-paraganglioma. So let us put a table where you have SDHA related problem and SDHB related problem and SDHC related problem and SDHD related problem, and finally you have SDH5 or SDHAF2 related problem. If they ask you which is the most common mutation of SDH which results in Pheo-paragangliomas, PPGLs, answer is SDHD. That is the most common. Almost 50% of paraganglioma syndromes which I'm going to discuss are due to this SDHD only. That's the most common. Clear? Similarly, if they ask you which is most dangerous mutation, that is SDHB mutation, this is the most dangerous because they are associated with more risk of malignancy and more risk of metastatic disease. That is the reason why SDHB is the most dangerous. SDHD is common but not so dangerous. So what is the chromosome number of SDHA? 5. Chromosome number is 1 year, 11 and 11. So this is the chromosome that produces different subunits. Inheritance pattern: autosomal recessive inheritance for SDHA, autosomal dominant inheritance for B, autosomal dominant inheritance for C, and maternal imprinting is the reason for this SDHD mutation and SDH5 mutations. Probably SDH5 is also associated with autosomal recessive mutations as well. Functions we described already. So which is important for substrate binding, catalysis, electron transfer, then ubiquinone binding, then flavination of SDHA. So different functions we have seen already. And what will be the clinical features of these different proteins? Usually SDHA will not produce Pheo-paragangliomas. Instead, they will produce necrotizing encephalopathies. That's been proven. But Pheo-paraganglioma risk is very, very low with SDHA. SDHD mutation, since they are more common, they tend to produce a syndrome called paraganglioma type 1 syndrome. And this SDH5 mutations, which is second most common, results in paraganglioma syndrome type 2 or PGL2. And this SDHC mutations will result in paraganglioma 3, and SDHB mutations will result in paraganglioma type 4. For that matters, if they ask you the most common form of familial paraganglioma is PGL1. If they ask you most dangerous form of familial paraganglioma, it is PGL4. Clear? They can be asking in this way also. And what will be the features of this PGL1, which is the most common? Remember, they can produce these PGLs, and most often they will be having a parasympathetic paraganglioma, which generally tends to be asymptomatic. They usually do not produce pheochromocytomas and sympathetic paragangliomas, which means most of the time they will be non-functional only. They will not produce a functioning pheochromocytoma or a sympathetic paraganglioma. And they generally tend to be non-secretory. Even if they are secretory, they produce this norepinephrine and probably dopamine, but they will not produce hormones usually. So if they ask you what is the marker that you are going to use for this, you are going to use methoxytyramine, because even if they secrete or do not secrete, they produce a little slight excess of dopamine production. That means your methoxytyramine will be elevated. So marker for PGL1, the most common form due to SDHD mutations is methoxytyramine. And they are non-secretory and non-functional. And they produce this asymptomatic parasympathetic paragangliomas only. And what about PGL type 2? PGL type 2 also tend to produce this parasympathetic paragangliomas, which generally tend to be asymptomatic. They generally tend to be a little late compared to other form of familial paragangliomas. The age distribution can be wide, but even though they can happen very late, like 16 to 18 years, and they are marked by very slow growth of the tumors. Usually they will be having tumor growth of less than 1 centimeter per year. Very, very slow growth of the tumor. And if they ask you the marker for this PGL type 2 or SDH5 related paraganglioma, it is normetanephrine. So you have to know this. Clear? So because they tend to produce more norepinephrine, that is the reason. And that's why I told you the production of epinephrine or norepinephrine will be dependent on the genetics. Very important. And PGL3 can be associated with both pheochromocytomas and sympathetic paragangliomas as well as parasympathetic paragangliomas. Clear? And the marker is normetanephrine once again for PGL type 3, and PGL4 is SDHB, most dangerous type. So usually they will be associated with large sympathetic paragangliomas. Usually they will be extra-adrenal. They do not produce pheochromocytomas. Instead, they produce large sympathetic paragangliomas, plus risk of other tumors are also there. Like they can produce a renal cell cancer, they can produce a thyroid cancer, and they can produce a breast cancer as well. And marker must be both metanephrine as well as normetanephrine because they produce large functional sympathetic paragangliomas. They produce both epinephrine as well as norepinephrine. That is the reason. Usually, this SDHA will not result in any paraganglioma. Very rare to have a paraganglioma. This necrodescing lymphadenopathy, encephalopathy that is associated with SDHA mutations is called leak syndrome, otherwise referred to as PGL5. If at all they result in paraganglioma, but generally extremely rare. They don't result in paraganglioma. And what is the risk of malignancy? If they ask malignancy risk, very low with all other paraganglioma syndromes. All other paraganglioma syndromes, the risk is low, except this SDHB mutations, that is this paraganglioma type 4, where the risk of malignancy is very high, in the range of 30 to 50%. Clear? Similarly, multifocal disease. So remember, malignancy here I mean by metastasis. Multifocality is different from metastasis. Remember, the same disease present elsewhere in similar areas. Like this is a ganglionic disease. Similarly, if you see in other ganglion regions, that is multifocal disease. If you see the disease in non-ganglionic regions like liver, lungs, and bone, so this is a metastasis. This is malignancy. But if you see in other non-ganglionic regions, that's not a sign of malignancy, but just a sign of multifocal disease. That's all. Multifocality is a clear-cut feature of SDHB mutation, that is PGL type 4, and this SDHD, that is PGL type 1. In other familial PGLs, you will not usually result in multifocal disease. So clear? So these are very important differences that you have to know. But apart from that, two most important points is SDHD, that is paraganglioma syndrome type 1, tends to be the most common, and you tend to have this multifocal disease, but malignancy risk is generally less. But apart from that, this SDHB tends to be not so common, but this is very dangerous because very high risk of both malignancy as well as this multifocal disease. And this SDHB related familial PGLs are referred to as PGL type 4. Clear? So very important, very, very important. And this is what is the future institute material. So this is what they're going to ask in the institute exams. So now let us discuss some things on the metastasis, metastatic disease. As I told you, metastatic disease is the only evidence of malignancy with respect to Pheo-paragangliomas. Only evidence of malignancy with respect to PPGLs, Pheo-paragangliomas, which means whenever you have a vascular invasion in a biopsy or in a resected specimen in histopathology, vascular invasion is not suggestive of a malignancy. Not suggestive of a malignancy. Even though there are a lot of scoring systems that can tell you whether the tumor is likely malignant or benign, but HPE is a very poor indicator of detecting malignancy in case of Pheo-paragangliomas, which means this vascular invasion is a feature of benign Pheo-paragangliomas itself. So only evidence of malignancy with respect to Pheo-paragangliomas is the presence of this metastasis. That is why this metastasis is a very important word with respect to this PPGL. So remember, metastasis is not the same as multifocal disease, as I told you already. So metastasis means it should be seen in non-ganglionic regions. It should be seen in non-ganglionic areas, like for example, liver, lung, or the bone. Remember, usually the site of metastasis also tells you the prognosis and survival, and bone metastasis generally tend to have a improved survival compared to that of liver and lung metastasis generally tend to have a low survival. Clear? And what are the predisposition to metastatic disease and malignant disease? As I already told you, the SDHB mutation, that is familial PGL type 4, is going to be associated with high risk of metastatic disease and malignant disease, and at the same time, this presence of paraganglioma itself is going to have a very high risk of metastatic disease. Almost 50% of the patients who's having paragangliomas will have this metastatic disease. But remember, pheochromocytoma, which means only adrenal tumor, has only 10 risk of being malignant and becoming metastatic. But whereas this paragangliomas, which means it's tumor that is not seen in the adrenal medulla, that's a chromaffin or a non-chromaffin tumor not seen in the adrenal medulla, is what we refer to as a PGL. So presence of PGL itself is a risk factor for developing malignant and metastatic disease, which is a very important point once again. So this metastatic disease can be either a synchronous metastasis or it could be a metachronous metastasis as well. So you might either see a synchronous metastasis, that is metastatic disease and the primary disease presenting at the same time, or you can have a metachronous disease also, where the metastatic disease will present very late after the initial primary disease. So which means the latency of this metastatic disease to present can be up to 5.5 years, which means the mean malignancy expression of this Pheo-paragangliomas can be up to 5.5 years. And this point is very important because this is the reason why we need a long-term follow-up with respect to this pheochromocytomas and paragangliomas, which means they can produce metastasis even after 5-6 years also. So maybe that time when the primary disease is presenting, the patient may be not showing that metastatic disease. It might happen after 5 to 6 years where it might surface out. That is the reason why this long-term follow-up is a very important point in case of a Pheo-paraganglioma. Similarly, the risk factors for metastatic disease depends on the size of the tumor also. Especially if the tumor size is more than 6 centimeters, there is high risk of being malignant and being metastatic. So, these are some of the important points that you have to know with regards to metastasis. But the most important point is the fact that vascular invasion is normal even in a benign Pheo-paraganglioma. So, it's not suggestive of any malignant disease. The only evidence of malignant disease with regards to the Pheo-paraganglioma is the presence of metastasis. That's a very important point. So, next moving on to the clinical presentation.